Good morning, doctors. I'm Dr. Daisy Muniz Flores, first-year resident. Today, I'm presenting to you a case of pneumocystis pneumonia in a person with acquired immune deficiency syndrome. My objectives for today is to present a case of a 56-year-old male with acquired immune deficiency syndrome who developed pneumocystis pneumonia, to discuss the epidemiology and incidence of PCP in the Philippines, to discuss the pathophysiology, the clinical presentation, diagnostics, and the current clinical practice in its treatment. For the general data, this is a case of a 56-year-old male, single, Roman Catholic who lives in Olongapo City, Zambales. Patient came to the emergency room with the chief complaint of dyspnea. History of present illness started 2 weeks prior to admission. Patient developed non-productive cough associated with on and off undocumented fever, with occasional shortness of breath and body malaise. No dysuria, no sore throat, and no nausea and vomiting. This prompted consult to a private institution, wherein a full workup was done. His blood tests were normal. 2D echo was unremarkable. However, chest X-ray revealed pneumonia. Patient was sent home with sultamicillin, levocetirizine, and nebulization. Few hours prior to admission, persistence of symptoms and progressive exertional dyspnea prompted patient to seek consult at the emergency room and was subsequently admitted. For the past medical history, patient is a diagnosed case of hypertension with coronary artery disease since 2019, no diabetes mellitus, no bronchial asthma, no history of malignancy, tuberculosis, and previous hospitalization. Patient is compliant in taking its medications. Patient has an unremarkable family medical history. For the personal and social history, patient is a 3.9 pack-year smoker, a non-alcoholic beverage drinker, and denies illicit drug use. For the sexual history, patient claims to have unprotected homosexual contact for several years. For the review of system, there was a note of 5 kg weight loss in a span of 2 weeks, and a chronic diarrhea for 3 months, 3 to 4 times per day. At the emergency room, on physical examination, patient was weak-looking, wheelchair-bound, and was in respiratory distress, with blood pressure of 130 over 80 mm mercury, tachycardic, tachypneic, febrile, with an O2 saturation of 80% at room air. Upon auscultation, fine bibasal crackles were noted. For the salient features, we are presented with a case of a 56-year-old male with 2 weeks history of non-productive cough, on and off fever, associated with body malaise, progressive dyspnea on exertion, with history of antibiotic treatment with poor response, history of unprotected homosexual contact, weight loss of 5 kg in a span of 2 weeks, with chronic diarrhea for 3 months, presents at the emergency room weak-looking, wheelchair-bound, on respiratory distress with fever and decreased oxygen saturation. For the pertinent negatives, patient has no oral trash, pharyngitis, anorexia, nausea and vomiting, dysuria, penile discharge, no oral lesions, lymphadenopathies, and skin lesions. For my differential diagnosis, first, I consider community-acquired pneumonia because of the history of cough, fever, body malaise, and upon examination, patient is febrile, tachycardic, tachypneic, with bibasal crackles upon auscultation, and during this time, I cannot totally rule it out. I also considered pulmonary tuberculosis because of 2 weeks history of cough, fever, and weight loss, and during this time, I cannot totally rule it out. Initial laboratories at the ER revealed normocytic normochromic anemia, normal creatinine and electrolytes, and sinus tachycardia on 12-lead ECG. Chest X-ray done on PA lateral view revealed minimal alveolar edema on both lower lobes and perihilar areas, no blunting in the costrophenic angle. At this time, patient was initially diagnosed with CUP-MR presumptive PTP to consider immunocompromised state. For the course in the ward, on the first day of hospitalization, still with non-productive cough, fever, and 3 episodes of watery stool with no dyspnea, patient has a stable vital signs and improved oxygen saturation level of 98% with oxygen support at 2 to 3 lpm via nasal cannula. Upon physical examination, patient has fine crackles bibasal with flat abdomen, hyperactive bowel sound, soft and non-tender. Fecalysis was requested with unremarkable result. Patient was referred to a pulmonologist for co-management wherein ceftriaxone, clarithromycin, and acetylcysteine were started. During the interim, patient became progressively dyspneic with oxygen saturation of 31% even with face mask at 10 liters per minute. Patient was tachycardic, tachypneic, with cyanotic nail beds. ABG result reveals compensated metabolic acidosis with secondary respiratory alkalosis severe hypoxemia. Patient was immediately intubated and was hooked to mechanical ventilator. Patient was transferred to ICU. Antibiotic was shifted to piperazine tazobactam 4.5 gram. Endotracheal tube aspiration GSCS, KOH, AFP gene expert were requested. 1 hour after intubation, patient's vital signs improved, with an ABG of overcompensated hypoxemia. During this time, our working diagnosis is acute respiratory failure type 1 secondary to acute respiratory distress syndrome. Chest X-ray post-intubation revealed intact endotracheal tube with its tip at the level of T2 to T3. Examination shows ground glass opacification of both entire lung fields, obscuring the cardiac margins. Both sulci are blunted. Repeat CBC was requested with unremarkable result. During the interim, still with 3 episodes of loose stool with stable vital signs, patient was referred to gastroenterologist wherein stool culture was requested with unremarkable result. Endotracheal tube aspiration result reveals positive for fungal growth and staphylococcal infection, negative for acid pass bacilli and culture. Patient was referred to ICC, revealing a CD4 count of 22 cells per cubic microliter. The initial HIV screening reveals a positive result. Hence, fluconazole, cotrimoxazole, isoniazid, and hydrocortisone were started. To control the diarrhea, loperamide was given. Our working impression during this time is acute respiratory failure type 1 secondary to acute respiratory distress syndrome with pneumocystis pneumonia and acquired immune deficiency syndrome. 3 days prior to discharge, patient improved clinically, no loose bowel movement, and no dyspnea. Patient was extubated with stable vital signs and normal ABG result. Gene expert reveals negative for Mycobacterium organism. Chest X-ray prior to discharge revealed a complete clearing of bibasal haze. Patient was sent home with the following medications: cotrimoxazole, isoniazid, fluconazole, and prednisone. After discharge, patient was referred to shelter for the initiation of antiretroviral treatment. For the discussion, Pneumocystis hirubetchi is an opportunistic pathogen that is an important cause of pneumonia in immunocompromised hosts, particularly those with HIV infection, organ transplants, or hematologic malignancies, and those receiving high-dose glucocorticoids or certain immunosuppressive monoclonal antibodies. For the history of this pathogen, in 1906, pneumocystis was first discovered by Dr. Chaga and confused it with Trypanosoma cruzi as a protozoan. In 1910, Dr. Antonio Carinai observed the pneumocystis infecting the lungs of rodents. They confirmed that the parasite was different from Trypanosoma cruzi and called it Pneumocystis carinii, another form of protozoa. In 1952, a Czech parasitologist, Otto Jirovec, discovered pneumocystis pneumonia in humans. From his study, he reported that Pneumocystis carinii is the cause of interstitial pneumonia among neonates. In 2002, organism was classified as yeast or a fungus, according to a molecular analysis of ribosomal RNA related to Saccharomyces cerevisiae. For the epidemiology, Philippines is a low-middle income tropical country in the Southeast Asia. Infectious diseases remain the main cause of morbidity. AIDS or HIV prevalence is still low at less than 1%, but it is rapidly increasing. This table shows the population of HIV/AIDS cases in the Philippines from January 1984 till August 2019. Last year, from January to August 2019 alone, we have a total of 8,711 new cases of HIV/AIDS. 95% of the newly diagnosed were male, with an age range of 1 to 72 years old, with 530 reported deaths. More than a third of HIV cases are found in NCR. Here in Olongapo, we have a total of 332 HIV/AIDS patients enrolled in lead shelter since 2011 up to 2019. Currently, here in Olongapo City, we don't have a census of patients with opportunistic infection. In the Philippines, pneumocystis pneumonia is the second most AIDS-defining illness at present, next only to tuberculosis. In a case series done at the University of the Philippines, Philippine General Hospital, Sagip Clinic, pneumocystis pneumonia is second to tuberculosis as the most common opportunistic infection in a patient with AIDS. The mortality rate is 8% in 50 cases, but this is likely an underestimation since some patients who presented with PCP as their AIDS-defining illness died before being enrolled in the clinic. For the pathogenesis and pathology, the life cycle of pneumocystis involves both sexual and asexual reproduction, and the organism exists as a tropic form, a cyst, and a pre-cyst at various points. Pneumocystis organisms are species-specific. Thus, a human are infected only by other humans who transmit Pneumocystis hirubetchi. Humans cannot be infected with species of pneumocystis that infect other animals such as Pneumocystis carinii in rats, Pneumocystis murina in mice, and Pneumocystis auricularia in rabbits. Most humans are infected with pneumocystis early in life. CD4 T cells are critical in the host defense against pneumocystis. Among HIV-infected patients, at least 80% of cases occur at a CD4 count of less than 200 microliter, and most of these cases develop at counts of less than 100. Pneumocystis has a unique tropism for the lungs. It is presumably inhaled into the alveolar space, where it proliferates, provoking a mononuclear cell response. The alveoli become filled with proteinaceous materials, resulting into alveolar damage. Interstitial edema and fibrosis may develop. At this point, the organisms can be seen in the alveolar space with silver or other stains. HIV-infected patients with PCP present with a prolonged subacute course. The most common symptom is vague sense of dyspnea, especially on exertion. Patients may also present with fever. A dry or minimally productive cough is typical and may be associated with pleuritic chest pain, with progressive shortness of breath, and ultimately resulting in respiratory failure and death if not treated. On examination, auscultation findings are usually normal, but sometimes diffuse fine crackles may be appreciated. There could be signs of hypoxia, including cyanosis and tachypnea. Accessory muscle use with intercostal retraction and diaphragmatic breathing may be present, depending on the severity of the illness. Patient may have history of antibiotic treatment for bacterial pneumonia with poor response. Severity of pneumocystis pneumonia is determined by the severity of hypoxia. For mild cases, a patient may present with an room air arterial oxygen more than or equal to 70 mm mercury, or an alveolar arterial oxygen gradient of less than 35 mm mercury. For moderate, alveolar arterial oxygen gradient of more than or equal to 35 and less than 45 mm mercury. For severe cases, an alveolar arterial oxygen gradient of more than or equal to 45 mm mercury may be seen. For the diagnostics, chest X-ray findings may be variable. About one-fourth have a normal chest X-ray early in the course of the disease. According to Harrison, the classic radiographic appearance of symptomatic PCP consists of diffuse bilateral interstitial infiltrates that are perihilar and symmetric. Another finding is the interstitial infiltrates that can progress to alveolar filling. The picture on the right side is from Harrison. It's a posterior-anterior lateral radiograph showing symmetric alveolar infiltrate. The picture on the left is the actual X-ray film of our patient showing minimal alveolar edema in both lower lobes and perihilar areas. A high-resolution chest CT scan shows diffuse ground glass opacities in virtually all patients with PCP. These two pictures are from Harrison. The common laboratory abnormalities in patients with PCP include an elevated LDH, a low pulmonary arterial oxygen and on arterial blood gas, and a complete blood count typically showing a normal WBC count, unless there is concomitant bacterial infection. For the definitive diagnosis, specialized stains can be used, wherein the pathognomonic picture of PCP can be demonstrated, which is a foamy, vacuolated, alveolar exudates composed of largely viable and non-viable organisms. Another method is PCR of oral secretions. For the treatment, the treatment of choice for PCP is trimethoprim sulfamethoxazole, 800 mg per 160 mg per tablet, 3 to 4 times a day for 21 days. In case the patient cannot tolerate cotrimoxazole, alternative medication are available such as atovaquone, clindamycin plus primaquine, and pentamidine. vaccines as Permaquin is available in the Philippines. Therapy with glucocorticoids should be the standard of care for patients with HIV infection and probably is also effective for patients with other immunodeficiencies. Viral treatment should be started within the first 2 weeks of therapy for PCP in most situations. According to the study, in patients with suspected PCP, it is usually prudent to give broad-spectrum antibiotic therapy with Pseudomonas coverage until the bacteria or mixed etiology pneumonia can be ruled out. Because of the severe immunocompromised condition of an AIDS patient, it is not unusual for multiple etiologic agents to be present. Tuberculosis in particular can be present and may be exacerbated by empiric steroids. A proton pump inhibitor or H2 blocker should be used adjunctly in any patients treated with high-dose steroids. Mechanical ventilation is also needed to maintain oxygenation if in case the patient result into respiratory distress. Response to therapy. A continuous pulse oximetry, serial ABG, and serum LDH can be used to gauge patient's response to therapy. A patient with suspected PCP should remain in the hospital for at least 72 hours even in the presence of dramatic clinical improvement due to the risk of developing ARDS. Criteria for discharge. Clinical improvement and weaned off from oxygen support and able to tolerate taking oral antibiotics and steroids are the criteria for discharge. The indication of primary prophylaxis are CD4 count of less than 200 cells per cubic millimeter, a CD4 percentage of less than 14% of the total lymphocyte. The most effective method of preventing PCP is to eliminate the cause of immunosuppression by withdrawing the immunosuppressive therapy or treating the underlying cause. Trimethoprim sulfamethoxazole is the main chemoprophylactic agent given as one single-strength tablet daily or one double-strength tablet once a day, and this should be continued until CD4 count is consistently above 200 cells per cubic millimeter for at least 3 months. Alternative agents include dapsone, pyrimethamine, eucoverin, pentamidine, and atovaquone. If the CD4 count increases to more than 200 cells per cubic millimeter for at least 3 months, or an HIV RNA remain below the limit of detection despite CD4 count of 100 to 200 cells per cubic millimeter for at least 3 months, a primary prophylaxis can be discontinued. But if the CD4 count becomes less than 100, regardless of the HIV RNA, then we need to restart the prophylaxis. Preventing subsequent episodes of PCP after treatment is the secondary prophylaxis. Cotrimoxazole, 1 tablet double strength once a day, or cotrimoxazole, 1 single strength per tablet once a day should be continued until CD4 count is consistently above 200 cells per cubic millimeter for at least 3 months. Same consideration is being followed in discontinuing secondary prophylaxis. But even in the case that the PCP count of CD4 count of more than 200 cells per cubic millimeter while on antiretroviral treatment, it would be prudent to continue the PCP prophylaxis for life, regardless of how high the CD4 count rises due to the antiretroviral treatment. Thank you.